Yeah, put it up there.
Good afternoon. Good afternoon. Please continue to enjoy your lunch, take your time, but we're going to go ahead and get started so we have plenty of time for our lecture and plenty of time to get everybody back for their afternoon activities. Welcome to the 16th Annual Robert Huntley, MD, Visiting Professorship and Lecture, which is intended to inform and inspire physicians, learners, and community members who are interested in healthcare innovation. This is done not only through an insightful presentation, but also by having the visiting professor spend several days in our community, sharing ideas, stimulating discussion and debate, and meeting with inspired leaders at all stages of their careers. This year's Huntley Lecture is also the kickoff to our year-long celebration of the 50th anniversary of the UNC Department of Family Medicine, which was established in 1970 by legislative decree from the North Carolina General Assembly, and to this day remains committed to creating a health system that provides compassionate, effective, cost-efficient, and patient-centered care to all the people of North Carolina and beyond. We welcome you all to the Huntley Lecture and invite you to join us in celebrating the hard work and accomplishments of UNC Family Medicine as we look forward to serving the state and the nation for the next 50 years. Before introducing our visiting professor, we'd like to remember and acknowledge two people who had a significant impact on our department. First, Dr. Robert Smith, who died last month just short of his 99th birthday. Of British origins, he was the founding chair of our department and a leader in the discipline of family medicine in the United States. Second, we mourn the death of Dr. Joan Huntley, who died last August. This visiting professorship was made possible by the vision and philanthropy of Joan, who established this event in memory of her husband, who, though trained as an internist, was an early advocate for rural and community health based in family medicine. Joan was an academician, an epidemiologist, and a researcher whose lively engagement in our state included not only advancing public health, but promoting the arts. And she was a passionate collector and supporter of art in North Carolina. She was a dynamo and an inspiration to all who had the privilege to know her. Her estate, once settled, will continue to support this lecture. And in the meantime, we are grateful to the Residence Inn of Chapel Hill, who stepped up by making a gift in Joan's memory to ensure the lecture was held this year. And now our speaker. Dr. Doug Henley serves as Executive Vice President and CEO of the American Academy of Family Physicians, of which he has been a member since 1973, and which he has led for 20 years. The AAFP represents 135,000 practicing family physicians and medical students nationwide. Dr. Henley serves on numerous boards and organizations, including the Patient-Centered Primary Care Collaborative. He was a founding member of the Ambulatory Care Quality Alliance and now serves on the steering committee of the Core Measure Collaborative and the Friends of the National Quality Forum. He previously served as a commissioner at the American Health Information Community, which is a federal advisory board, and was one of the inaugural commissioners of the Certification Commission for Healthcare Information Technology. We would be honored to have Dr. Henley as our Huntley Lecture any year, but this year it is especially fitting because his father played an important role in the establishment of our department. John Henley Sr. was a pharmacist in Hope Mills, North Carolina, who recognized that the medical care delivered to his rural community was limited and that the burgeoning specialty practices coming out of North Carolina's cities and academic centers was of little service to the people in his small town. When John Henley became Representative Henley and then Senator Henley in the state's General Assembly, he had the opportunity to do something to address the healthcare disparities facing small town and rural North Carolina. And he wrote the measure that directed the establishment of a Department of Family Medicine at UNC. Doug, to this day, we are indebted to your family for the foresight and commitment your father and others have shown regarding healthcare in North Carolina. And I want to take a moment to recognize that Doug's brother and UNC alumnus, Dr. John Henley Jr., is here today with his wife, Susan. Doug earned his undergraduate degree at UNC, his medical degree at UNC, and then completed his residency in family medicine at UNC. He then went back to his hometown of Hope Mills and practiced for 20 years. He was active in the North Carolina Academy of Family Physicians, an interest that grew into a national role, and in the year 2000, he was selected to serve in the position that he still holds at the AAFP. Dr. Henley, we are honored that you are here to give the 16th Annual Huntley Lecture.
Thank you, Margaret. Thank you all very much. Good afternoon, and great to be here. Good to see old friends. I'm just going to tell you ahead of time that we're going to have a ride during my speech, and I hope to be kind of an equal opportunity offender. By that I mean that it's important that we celebrate the 50-year history of this department, and we will. I'll go down memory lane, at least for me, here in just a moment. But I'm looking forward to the next 50 years. Here comes the emotions. I was going to warn you that I typically do this, but I'll get past it. Hope you do as well, and we'll move on. So time number one, I told the residents this morning. So, but I'm looking forward to the next 50 years because I have never been more excited about the future of family medicine than I am today. But I say this in the sense that you'll hear my top 10 list of challenges for the future here in just a moment. Let me get over to my agenda slide. And in that context, family medicine needs to be part of these solutions, and these solutions are not possible without family medicine. So keep that in mind going forward. So here's what we're going to do. We're going to go down a little bit of memory lane from my involvement with this department and its establishment and so forth. Then I want to go take you back to when I came of age in a time that was countercultural in this country that led to the birth of family medicine. I think there's a lesson to learn there, and perhaps we need to rediscover some of that countercultural bent of our past as we move forward. And then we'll move into the top 10. And that's where I'll be the equal opportunity offender. So let's move forward. So happy anniversary to the department. 50 years, hard to believe. 51 years for the specialty, because that was February the 8th, 1969, when the specialty was formed. But you are in great company. This is also the 50th anniversary of Sesame Street and public television. It's also the 50th anniversary of Scooby-Doo. The world is great with Scooby-Doo. I wish my wife Mary was here because she can imitate Scooby-Doo very well. You have to have her hear that. So let's talk about my dad. Thank you, Margaret, for your comments. This was it, House Bill 307 in 1969 that created the Department of Family Medicine, an equal department for $127,554. Margaret, don't you wish you could run the department on that much money now? Boy, amazing. Simply amazing. But let me tell you, and in that regard, John and I and my brother Bob, I think we rarely saw my dad angry. But I can remember I was the baby. John and Bobby in 1969, 68, 69 were already at Chapel Hill. I was a senior in high school. And I can remember in late November, December of 1968, the legislature was going to start in January, February the next year. And Dad came home from a meeting in Raleigh. I think he had met with folks from Chapel Hill as well as some of his colleagues. And I can remember him coming in, and he was angry, talking to my mother, Becky. And he said, these folks at Chapel Hill just don't understand. The House of Medicine has determined that family medicine would become a specialty, which it did in February of the next year. but they want to ignore the needs of the people of North Carolina. And so because of that, we're going to tell them they've got to do it. And my mom said, go do it. And he did. But some other things about Dad. He was passionate, obviously, about healthcare and health. He was passionate about transportation and highway safety. He was passionate about education and public health. So let me give you some other examples of his tenure. First of all, he and Mom moved to Hope Mills in 1946. 1 year later, he was mayor of Hope Mills. From 1947 to 1953, he served on the town council till 1956. But he was a pharmacist by profession, a legislator by avocation. The pharmacy was across the street from the clinic, which we would call today a critical access hospital of about 20 beds with the 2 family physicians working there. That's where I was born in 1951. And he saw the needs of the people of Hope Mills. Remember, this is late 1940s, early 1950s. And he saw a community that if they were going to advance, there was an economic opportunity and some public health needs that had to occur. There was no central water or sewer in Hope Mills at that time. It was septic tanks, outhouses, and wells. And guess what was prevalent? What infectious disease was prevalent then? Polio, transmitted by contaminated water. So Dad, as mayor, convinced the people of Hope Mills to raise their taxes and implement central water and sewer, public health, but also economic development. Fantastic. Road safety. When all of you at night in North Carolina drive on any road, especially if it's dark and rainy, pay attention to the white lines on the edge of the road that keep you on the road. Dad introduced legislation to mandate those white lines on North Carolina highways. We were traveling on a trip to Oklahoma. We were going through Tennessee or Arkansas. He saw a road with white lines, looked over again at Mom and said, that's a public safety issue, a highway safety issue. Mom said, why don't you do something about it? He did. Remember in 1931, there was legislation to consolidate the UNC system. That was primarily UNC, North Carolina State, and UNC Greensboro at that point in time. But in both 1969 and 1971, Dad upped the game to bring all the public colleges and universities under one umbrella. It's ironic that we are in the Friday Center. Dr. Friday was the first president of the Consolidated University. More about Dr. Friday in just a moment. Dad introduced that legislation, got a lot of flack from our friendly News and Observer about doing that. Dad was a great supporter about the funding of AHEC system that still flourishes in North Carolina. When obviously the federal dollars came in first and he was able to do some matching state funds. But when the federal dollars began to disappear, Dad worked with his colleagues in the legislature to increase the state funding, which continues today. A great system. It has been very helpful to the state. And again, he was a strong supporter and advocate for the medical school at East Carolina. Again, he was becoming disenchanted with the leaders at this campus for obvious reasons. Mr. Friday amongst them. And so again, while he fought with Mr. Friday about the department here, because Mr. Friday did not want this department in the name of institutional freedom, Dr. Friday did not want East Carolina University either. And they were friends in undergraduate school here at Chapel Hill. They remained friends till Dr. Friday and Dad died, but they argued over this, and I think Dad won. Now, a little bit about the department. I was privileged to meet, I heard that Dr. Robert Smith had died just recently, sad to hear, but I was privileged in 1973 as I began medical school from 73 to 77 to meet Dr. Smith, and he was indeed an inspiring individual. By the way, I was a little shocked when Margaret said I need to inform and inspire you. I can inform you, I'm not sure I can inspire you, but you've got that evaluation form on your desk. Remember, number 5 is the right circle for the Likert scale in terms of grading the lecture. But anyway, Dr. Smith was a very inspiring man. I was happy to meet him before he left Chapel Hill and went to the University of Cincinnati. The first family medicine clinic that I encountered as a resident was in the bowels of a Memorial Hospital with my 5 colleagues in 1977. But we quickly moved over to the first floor of Gravely, which was a marked improvement, both for us and for patients. And by that time, Ed Shahady was here. And I know Ed's not in the audience, but I owe a great deal of debt to Ed Shahady. Ed was a master teacher, a master of the teachable moment, really was. And Ed was the one who tapped me to go to an AAFP meeting in the summer of 1976, which was then the second meeting of the national conference, the third meeting of medical students, third meeting of residents. I think we had 100 people there, and now we have 5,000 at that meeting. Some of the students and residents here have been there, but that started, for me, that started 44 years of constant involvement, either appointed or elected in the AAFP, and I owe that entirely to Ed Shahady. When Ed decided to step down, I was contacted by Stuart Bondurant, then Dean of the Medical School, and Stuart asked me to serve on the search committee, which led to the appointment of Ken Reeb as the successor chair of family medicine. So I got to know Ken and Mary Reeb quite well. And then the picture of the new family, well, it's not the new family medicine center, the current family medicine center, and the plaque next to it, what I call the force, that's the North Carolina Academy of Family Physicians. There's a picture back there of both the groundbreaking as well as obviously the dedication of the center. Back in the dedication, groundbreaking was in 1988. I'll more about that in just a moment. But I can tell you that without the North Carolina Academy of Family Physicians and many past presidents that preceded me, that building would not have happened. I can guarantee you that. And then I was privileged to serve as president of the North Carolina chapter from the fall of 1987 to the spring of 1989. I was a slow learner, so they had to give me 18 months. But I was privileged in June of '88 to be at the groundbreaking. You see me on the far left. I actually had some hair then. To my left, your right, was Chris Fordham, who had previously been dean of the medical school, then was chancellor at UNC. C.D. Spangler's in the middle. He was president of the Consolidated University. Stuart Bondurant next to him, and then Ken Reeb. But I'll tell you an interesting story. Margaret was surprised when I told her this. 4 to 6 months before this groundbreaking occurred, all the money had been appropriated, plans were drawn, site had been selected, this groundbreaking had been scheduled, and I was in my office in Hope Mills in my practice, and Ken Reeb gave me an urgent, anxious call. Said, Doug, you will not believe this. Somebody on the campus, he did not name who that was, just called me and said that he had heard that there were plans by UNC to work through the transportation commissioners, whatever that title was, and they want to build a cloverleaf bypass at the corner of Manning Drive and 15501. You know, those big cloverleaf things. That would have destroyed that property, and they were serious about it. So I talked to my dad, who knew a friend of mine who was on the Transportation Commission. It was a Republican administration then. I called and gave him that story. He lived in Fayetteville. He already knew a little bit about the history of the building. He said, Doug, let me check on some things. I'll call you back. He called me back about 4 hours later and said, yes, the rumor is there. There are a few people at Chapel Hill that are serious about it, but it ain't going to happen. And so that idea of this big cloverleaf was gone away, and the building went ahead. So just interesting that UNC continued to try to resist supporting family medicine. Now, let's talk a little bit about counterculture, and I wanted to get to a little bit of prepared remarks on this so I wouldn't mess this up. So as I've reflected on my career, I feel very privileged that I, born in 1951, very privileged that I kind of came of age in the 60s and early 70s. As if you were born around that same time, you may remember this. If you were born after that, you can learn. These were years of great turmoil the Vietnam War, Civil Rights Movement, Watergate, the assassination of three dynamic leaders, Robert and John and Jack Kennedy, and obviously Dr. Martin Luther King. All events that, in my mind, led to this countercultural movement in our country that resisted the war, called for an end to segregation, and pushed for more transparency and accountability in government. Sound familiar? 50 years later or more? But they were also years of great opportunity. When government worked, the enactment of Medicare, Medicaid, think about this, Civil Rights Act of 1964, a year later, the Voting Rights Act. And it was also a time of major advances in science and technologies. We had the race to put a man on the moon, which we accomplished in July of 1969. 69 was a big year. I graduated from high school. Man on the moon, February 8th, family medicine was established. Dr. Gail Stevens, who many of you know was a pioneer in our specialty, described family medicine as a countercultural movement itself. When we began, we dared to insist on a training model based in the ambulatory environment, not just in the hospital or the bowels of the hospital, in a family medicine center that would allow for a continuity relationship of residents with patients over time. That was revolutionary in those days and countercultural. We called out and we challenged medical schools who refused to recognize our specialty. I can remember as a fourth-year student going to Kansas City and actually being in a debate with Dean Elliott Richardson from Emory, who was bound and determined that Emory would never have a Department of Family Medicine. I got a standing ovation because I said they should. Dean Elliott got thrown off the stage because a big lion roar came over when he went over his time. I was happy. But we as family medicine, we were feisty, we were pithy, we were in your face. It was fun. I was happy to be part of it. And frankly, I miss it a little bit, and I worry a bit that we become too much part of the system. I'll just put that out there, and I'll come back to it in just a moment. So much like the 60s and 70s, in this third decade of the 21st century, I think we again find ourselves in times of turmoil and opportunity. And in such an environment, I think family medicine can flourish if we continue to remember and go back to our countercultural roots and seriously challenge the status quo. So that's the context. So let's go into my top 10s. Now, I'll tell you that I could have come up with my top 25, but Margaret said I only had an hour versus 2.5, so I had to cut it down. So I'm sure I could go on, but these are my top 10. So number 1, remember Barbara Starfield said about 2.5 decades ago that the value of family medicine and primary care, improved quality, lower cost at the county, state, and federal level, and national level depends on the 4 C's of primary care. Primary care delivering on the 4 C's of comprehensiveness, continuity, care coordination, and first contact, accessibility. And then I'll come back to this notion of how we measure primary care today. We have a very reductionist model of disease-specific performance measures today that I think is not correct for family medicine. But we know that comprehensiveness and continuity matter. This is a series of articles in Annals of Family Medicine in 2015 that you all may have read by the Robert Graham Center and our colleagues from the American Board of Family Medicine. It clearly showed that as family physicians continue to practice comprehensively and with great continuity, there is cost savings, lower hospitalizations in significant degrees, and if they practice comprehensively, there is less burnout and greater satisfaction with practice. The data supports it. But I worry today that we are preparing our residents, as we always have, and we should, to practice comprehensively, but they can't find it when they graduate. And the department going forward, and the specialty, the academy, we have a responsibility to re-emphasize the need for residents to find this in practice. 23% want to deliver babies, but only 8% are doing so today. Over 50% want to do inpatient care, but only 33% are doing inpatient care. 50% want to do prenatal care, and yet only 9 or 10% are doing prenatal care. They can't find the comprehensive jobs. Shame on us. But I think it's important to train comprehensively because, as I've always said, residents, when they graduate, are like pluripotential stem cells. They can go out into any community they want to and adapt themselves to the needs of the community. Now, getting back to measurement, as I mentioned, I think that the reductionist model of process measures at the disease that are disease specific are driving us nuts and creating a lot of administrivia that's not improving the cost of the quality of care. Kurt Stange and his colleagues back in Annals of Family Medicine described it 11 years ago, the paradox of primary care. If you take these reductionist disease process measures like hemoglobin A1C and so forth, and let's just take diabetic care, and compare primary care with our subspecialty colleagues, yes, the endocrinologists may perform better on those process measures, slightly better, but if you look at the whole person in the population, family medicine wins hands down. Better quality, better health, greater equity, lower cost, based on population outcomes. We're measuring the wrong thing. We need to measure comprehensiveness and continuity and first contact. That's what we need to be measuring. That's what this department and the specialty can aspire to in the coming 5, 10, or the next 50 years. Hopefully we don't have to wait 50 years for it. How about length and place of training? I'll talk more about place, but initially about length. So many of you may recall that from 2012 to 2018, based upon the Future of Family Medicine project of 2004, it pointed to the need to consider, is a third-year curriculum appropriate in the 21st century, given the need for comprehensive training, or should we go to a 4-year curriculum or somewhere in between? So the pilot was between 12 and 18. There will be a series of articles coming out in the journal Family Medicine. The first one came out September of last year, and it'll be answering several specific questions. The first one was, if we go to a 4-year curriculum, will that be a negative impact on the match compared to 3 years? And this article in September suggests that no, there will not be any difference. Now, again, it was a small sample of 4-year programs, I understand that. But it's a conversation we need to have, and there will be other articles that will be coming out addressing scope of practice implications, et cetera. I don't have the answer. I frankly think that the 3-year curriculum is just fine, but it needs to continue to evolve. What I hope will happen, however, is that the ACGME, which is, as you all know, is the accrediting body of all residency programs, I would hope that they would allow family medicine, or would change the requirements for family medicine to say not just family medicine residencies are 36 months, but that family medicine residencies are at least 36 months. That way we can have experimentation and programs that want to go beyond 36 months. If they can find the funding and everything else and the reasons for them doing that, they can choose to do so, and let's experiment and learn. But it's a conversation we need to have without a predetermined outcome. And we know that place of training is important. This is the great article that Carr White here at this institution did in 1961 with his colleagues, New England Journal of Medicine, and it blew the academic people away. Because, not surprisingly for Dr. White and for all of us, but he showed that in a given month in 1961, if you take 1,000 people, about 750 of them will have some sort of symptom or health event. Most of that goes away. But as you continue to drill down and they interact with the healthcare system, only 9 of 1,000 will ever be admitted to a hospital, and only 1 will be admitted to an academic health center. 1 out of 1,000. And yet, where do we train people? That one person is not your typical patient in clinical practice. So place of training matters, and we need to pay attention to that. That doesn't mean we need to desert academic health centers in terms of where we train people, but we need to think about how do we train people to take care of the population. And the population in Memorial Hospital is not the average population of the U.S. people. I would argue that, or at least we need to question that. That research was repeated by the Robert Graham Center in 2001, showed exactly the same thing 40 years later. And we know that it matters. Place of training matters, especially in terms of cost. This initial article was in JAMA in 2014 about the cost implications and imprinting on training, better described, I think, in this article in Annals of Family Medicine in 2017. Listen to this. If we train residents in a high-cost environment, think hospitals, academic health centers, health systems, when they leave, for the next 15 to 20 years, they continue to practice high-cost medicine, even if they practice in low-cost areas. If you train in a low-cost area, you continue to practice low-cost medicine, even if you practice in a high-cost environment. Something's wrong with that picture. And we need to, wherever we train our residents, we need to train them not only to improve quality, but how they need to pay attention to cost and the decisions they make. Number 3, value-based payment. Alternative payment models, greater investment in primary care. So here's the food that feeds the beast. Fee-for-service medicine leads to volume over value. Fee-for-service, do as much as you can to as many as you can, and sometimes you do things you shouldn't be doing. And it leads to this. 25% of our $3.7 trillion probably represents unnecessary care, care of low value, duplicative care, unnecessary care, maybe a little bit of fraud. $700 to $900 billion. That's a lot of money fed by fee-for-service that could be reinvested in primary care and create a health system rather than a healthcare enterprise. And it's led to this. Family physicians and our internal medicine and pediatric colleagues in general internal medicine, we make up only 30% of the workforce. We do over half of all the ambulatory visits, and yet the system is only spending 5 to 7% of the total cost of care on primary care. 5 to 7%. In every other developed nation, OECD, where they have better population outcomes and lower costs, they're spending 12 to 17% of total cost of care on primary care. We need greater investment. We need to pay differently and better for primary care. I wonder sometimes what everybody else is doing besides primary care. 2 years ago, the Academy proposed to HHS an alternative payment model that would move from fee-for-service in the 4 quadrants that you see here, that would replace fee-for-service with a capitated model, separately risk-adjusted from a care management capitated model. There would be a component related to quality improvement. Residual fee-for-service would be necessary for those that do procedures in the office and so forth. It's a blended payment model. Not just fee-for-service, not just capitation, which pure capitation may have its own challenges in terms of under-treatment, a blended payment model. This was highly recommended by the Physician-Focused Technical Advisory Committee. Unfortunately, HHS has pretty well ignored it to date, although they did release, as many of you know, the primary care first model that they intend to implement in January of 2021. Some of you may be considering to sign up for that. We're cautious about it. It is kind of built on the chassis of this payment model that you see here, but we'll see how it plays out, and hopefully it will evolve and improve. But at least it does allow the opportunity to move away from fee-for-service. But here's the fundamental question for family medicine. If we want to achieve this greater investment in primary care as a percent of total spend, we've got to take some responsibility for risk in terms of controlling total cost of care. And if we are not, family physicians, if we're not willing to do that, this other reform will not occur. There's great power in this instrument called the pen and the cursor of an EHR in terms of who we refer to, what tests we order, and whether we order them or not based upon patient needs. So at some point we need to take this challenge in order to receive that greater investment. In 2006, the Academy collaborated with the American College of Physicians, American Academy of Pediatrics, and our osteopathic colleagues to promulgate the principles of the patient-centered medical home. We saw the medical home as a better expression of transforming primary care at the practice level to be more team-based, more of a team sport, more accessible, better management of the medical neighborhood. And here we are 14 years later, and the medical home model has been inculcated as part of the Affordable Care Act. And private payers, public payers are all, state Medicaid programs are all implementing the medical home model in various ways at the practice level. And I'm happy to say that more than 60% of our members on our surveys indicate that in one way or the other, they're trying to transform their practices to this better expression of delivering primary care. It's a journey that will never be complete. It will continue to evolve, but it's a journey that we as the Academy certainly will help our members be on. But it's important, I think, that we talk about the team and who the team is. And the team is not just a family physician. It's nurse practitioners, it's PAs, it's medical assistants, it's the pharmacy, it's the laboratory tech, it's the front office staff. And it's important, to, I think, to recognize that every member of the team is important, but they are not interchangeable. They are not interchangeable. And we need to be transparent with our patients as to who the clinician is that walks in the room and what type of degree they have. And I think we need to get away from this archaic expression of practicing to the top of your license, and we need to talk about training, experience, and demonstrated competence. That's what matters, and there's a great difference between how we all are trained at various levels and difference of experience and demonstrated competence. I still have a license to practice in North Carolina. I'm still board certified, but I haven't seen a patient in 19 and a half years. You don't want me in your exam room as a physician. Make a great patient. But anyway, training experience and demonstrated competence matter, and that's what should happen within the team. How about the street? Venture capital. In the last 2 or 3 years, there has been at least $30 billion invested in primary care by venture capitalists. Over $30 billion. Somebody sees value in primary care, and they're willing to invest in it. Private equity. There's institutional equity, private equity. And here's kind of where it is. Various models out there. Who will win? The model on the left is the kind of institutional equity of Walmart and CVS, retail clinic model with nurse practitioners. In the middle is venture capital with Adelaide, which is kind of a practice support model for small and medium independent practices. You know, I know they've got some presence here in North Carolina. One Medical and Oak Street are additional models of that, all physician oriented. Bottom right-hand corner, this may not be the right term, but there's many insurance models like Humana and Optum in United Health Group that kind of have a physician-led model, but they're primarily focusing on Medicare Advantage patients. So it's a capitated environment, but I worry in that environment that it's more like family physicians becoming adult internists without comprehensive practice. So I worry about that model going forward, just in terms of comprehensive care. But I don't know who will win. Maybe everybody will win. There are a lot of people out there, 350 million people. Half of them don't have a designated primary care physician that they can't name. So maybe there's room for everybody. But I think this is a huge, tremendous opportunity for family medicine to show the way that the physician model is what's important in a team-based environment based on the medical home. Let's talk about physician employment. 72% of our members are employed today. 90% of recent graduates are employed. But it's important, you know, when you hear that, I suspect most of you thought that they would be employed by a hospital or health system. That's only about 25% of them. Others are employed by multi-specialty and single specialty physician groups where they're the employer, not the owner. There's still 25% that are in independent practice and small groups and partial owners and so forth, some in the DOD and VA, et cetera, obviously university setting. So when we talk about employment, it's important to understand who the employer is in terms of type of practice. So that's the environment where we end. That you may think that this portends the end of independent small group practice. I would challenge that notion because of that 25% that's still residual on the right-hand side and because of this type of research. Again, Annals of Family Medicine 2016 showed that small physician-owned practices still deliver a better patient experience, lower hospital admissions, lower average cost per patient, compared to larger independent practices and certainly compared to hospital-owned practices. I'm sure more to come on this research, but there is a place and purpose for independent practice and small practice, and they can turn on a dime in terms of trying to orient and retool on changes in healthcare compared to larger systems. So that's one part of it. And here's another article, both from JAMA Internal Medicine. This was 2017. I think that speaks volumes that hospital-based practices are associated with greater use of low-value care, particularly MRIs and CT scans and more referrals compared to community-based practices. And hospital-owned community-based practices do greater referrals compared to physician-owned community practices. I'm not trying to challenge what you're doing here at UNC or what's being done across the country in health systems. I just think that there are many models of primary care that work, and we need to be supporting all of them. And importantly, it should always be about quality and lower cost, value. And if we know that in employed system-owned practices, we've got a problem with cost, let's work it and figure out how we change it. I'll come back to that. How about artificial intelligence? I can tell you, this is one reason I'm so excited about the future of family medicine, because I think we can use this technology to move upstream, and I'll mention that in just a moment. AI and machine learning, if you believe some of the proponents, there's a gentleman by the name of Vinod Khosla who was the co-founder of Sun Microsystems. He's a very edgy kind of guy. He was at a Toronto IT conference about 6 months ago, and as he's done over the last 3 or 4 years, he said, it's not a matter of if, it's just a matter of when. AI will enter medicine. It will enter the subspecialty environment much more quickly than primary care, because primary care is much harder for AI. Surprise. And he said, I mean, and he's quite the edgy guy. He said, in 15 years, oncologists will be toast. In 15 years, radiologists will be toast. He said that AI is easier to implement in oncology than it is to implement on a factory floor, because oncology is protocol-based. Now, whether he's going to be true or not, I don't know, but you've got folks out there saying that. We missed the boat back in the 1990s with the evolution of software for electronic health records and our influencing the need for that technology to integrate with the workflow of primary care, but it became all about bullets for billing. We are not going to miss the boat on AI. 2 weeks ago, the Academy had an IT conference in Silicon Valley, and we had AI startups and venture capitalists there, and they were asking us, tell us what you need in family medicine. And we're going to influence that going forward. But here's what artificial intelligence is going to do. What we do today in primary care, some of it will become the commodity of tomorrow, which will be able to be delivered by lesser trained individuals. But look at the upper right-hand column. Family medicine can move upstream. The less need for referral to subspecialty, particularly the medicine subspecialties. Why do you need an oncologist in the future if AI can deliver evidence-based clinical decision support to the point of care? Family medicine can do that. Same with rheumatology, etc. Family medicine can move upstream by taking advantage of this technology, not downstream. We should engage this and be excited about the potential to deliver better care. And look at the bottom left-hand corner. AI will empower patients and their families to do better self-care. That's a good thing. We should be supportive. And I think this is my slide about the future of family medicine, that it delivers on the quadruple aim. In the short run, I think AI in the next 3 to 5 years, I think AI can solve the administrivia that you all have to deal with today. The administrivia of performance measurement and reporting, the administrivia of prior authorization, and the administrivia of documentation. There are 90 startup companies today that are working on a virtual scribe, think an Alexa device in your exam room, so you will no longer need to have a keyboard in the exam room. You'll have a conversation with your patient, and the documentation will automatically occur via the AI-empowered EHR. 90 startups that are doing that now. We're working with one called Suki, and they have markedly improved their product just in the last 12 months. So this is coming. In the medium term, I think as we move more to value-based payment, I think artificial intelligence will be able to deliver at the point of care cost and quality data to family physicians, so you can know better about to whom and where to refer if referral is necessary. That's kind of the holy grail of primary care to some extent. And then in the future, the distant future, again, I think we'll have more of that clinical decision support for family physicians to move upstream, as I mentioned earlier. Here's an important one. How about family medicine committing to health equity? There's a difference now. Remember, there's a difference between health equality and health equity. Health equality is where everybody gets the same thing. Health equity is where people get what they need for better health. And family medicine needs to be there. Now this slide ought to really embarrass you, make you angry, and tick you off. So here we are all the way back. This is life expectancy versus dollars spent for developed nations from the 1960s to 2018. And look at the good old US of A compared to everybody here. Here's where we were back in the 60s, 70s. We started reasonably well with Medicare and Medicaid, but boy, then we've gone off the chart. Now, you've heard a lot about the last 3 years where life expectancy in this country declined year over year. It's the first time since it's been measured in any developed country where life expectancy has gone down 3 years in a row in the good old US of A. Last year it went up 1/10 of a point, woohoo! But we aren't talking about all this in the delta here. How can we be excited about that? Shame on us. Now there are many reasons for it, and also look at maternal mortality. It is far less safe today for a woman to have a baby than in the 1990s, and especially if you're an African American female, it's far higher, far worse, even if you're an educated African American female. Shame on us. Got a lot of work to do. Now, there are many reasons for that. We can talk about that during the Q&A if you want to. Here's the usual slide you've all seen about this is percent of spending compared to GDP. No surprise there. But look at this in terms of spending on social support. All those other countries that have better population health outcomes, lower costs, they're spending far more on social support services. They're spending more on health and less on health care. And we're doing the exact opposite and have been. There's a role for family medicine here. We need to change the conversation. And I know under Margaret's leadership and Christy's leadership and all of you, you're paying attention to that. You just rebranded to UNC Health. That says something. Not healthcare, UNC Health. It makes a statement. Now deliver on it. Going back to this, because I think there's another story here that's very important. Because again, I think something else, whoops, whoa. I hit the wrong button here. Go back here. There's another story here. What else happened in the 60s and 70s that's important here, that's part of the message, I think? That's when, I think, especially after World War II, this nation made an interesting decision. Rather than going towards universal access, we went for a pluralistic system and we went for subspecialty care and we left primary care behind. And it's resulted, I think, significantly in this. Not the only answer, not the only issue. Back in the 1990s, 23% of family physicians were doing OB. Today, it's 9%. Correlation? Outcome? Don't know. Maybe. Family medicine is a big answer here, and it's supported by the literature. Just last year, JAMA Internal Medicine by Basu and his colleagues said if you add 10,000 primary care physicians per 100,000 population, life expectancy goes up by 51 days, a 2.5 time impact compared to increasing subspecialty physicians. 2.5 times greater impact. 51 days may not sound like a whole lot of increase in life expectancy. The experts tell me that's a big difference. Just because of the presence, the increasing presence of family medicine primary care. Has nothing to do with payment, has nothing to do with the medical home. It's simply the presence of primary care. We have work to do. How about health care coverage for all? Mr. Churchill, I think, said it well. You can always count on the Americans to do the right thing after they've tried everything else first. And I think that's what we've been doing since 1965. We have tried everything else in this country except primary care. And it's led to what I think is a healthcare enterprise. Notice I didn't use the word system, a healthcare enterprise that's designed to it's uniquely American, designed to cost a lot of money, designed to make some people a lot of money, and it hasn't delivered on the promise to the American people of improved quality and lower cost. We need to move to a system that delivers on that promise. Higher quality, lower cost, and that system needs to be based in family medicine and primary care. So, in 1988, the Academy was the first medical association to call for universal coverage, healthcare coverage for all. And in the fall of 2018, our Congress of Delegates adopted this policy. You can find it on our website. I and one of my senior vice president colleagues primarily wrote this policy. I'm very proud of it. It calls for affordable health care coverage, but also based in foundational primary care. Come back to that. And I would argue very strongly that both are necessary to be successful. If we only focus on coverage, even affordable coverage, Mr. Churchill will again be right, that system will fail if it's not based in foundational family medicine and primary care. What does foundational primary care look like? Well, how about a greater investment in primary care, changing the payment model that we've talked about, greater investment, and importantly, benefit design that's favorable to primary care, that makes primary care the gateway into the system. Not a gatekeeper, gateway into the system. And given the fact that we spend $15 to $16 billion of Medicare money, your and our taxes, we need some rational approach to the workforce needs of this country. And we need to change the GME funding spectrum so that we train, so it's more favorable to family medicine, primary care, general psychiatry, general surgery, not just primary care. We're training too many subspecialists. They would argue that point. We need to prioritize. Now, I'm going to finish with number 10 about countercultural. And again, equal opportunity offender. So, first one, holding academic health centers accountable for their social mission. So let me read you something from, again, the Journal of Family Medicine. John Saltz, who's a good friend of mine, former chair of Family Medicine Oregon, editor of Family Medicine, he wrote this in November of 18. Examined as a national system, it is hard to dispute that American medical schools are failing in what should be their social missions. In too many schools, the social mission has become something rolled out by the marketing department whenever there is a squeeze on funding or an adverse article in the local newspaper. Too many schools have become paragons of self-interest, pursuing profit and scientific acclaim while expecting others to look after the public. So what does this mean for those of us who work in family medicine departments in medical schools? As population health becomes more important in the marketplace and reimbursement models change, medical schools face a growing need for more primary care. They need us. Now, question, is it our job to protect these institutions from their own excesses? On what basis do we think doing so will help the American people? Family medicine got its start as a discipline promising reform, and we are now at our 50th anniversary. Have we delivered real reform, or have we become well-paid apologists for the institutions in which we work? Food for thought. I'm not saying that's the situation here at UNC, but I think our departments and our academic centers need to consider their social missions, their delivery on their social missions, and we need to go back to our countercultural roots and always dare to challenge the status quo and move these institutions forward. How about scope of practice? And here I'm talking about not MPs and PAs, but the comprehensiveness of training. So again, I'll read you two quotes, both from Family Medicine, 2018. The first is from Andrea Wendling, who described it this way: as we allow our specialty to be defined predominantly by ambulatory adult medicine services, we also risk inviting a path to our own extinction. And this is from Josh Freeman, who was former chair of family medicine at Kansas University in Kansas City, who said, if our scope of practice as family physicians is changing and becoming more narrow, is it because we either want it to be, or are we unwilling to stand up to those who are narrowing it for us? Now, I was a fan. How many people remember the old black and white TV show Lost in Space? Fess up. Okay. I love the robot in that TV show, and when the young guy Will Robinson, and the robot Will would get into some crazy endeavor, and the robot would say, "Danger, Will Robinson! Danger, Will Robinson!" This may be our danger, Will Robinson moment. This need to continue the comprehensiveness of the scope of our practice. Danger, Will Robinson. How about the ethics of consolidation, wherever it may be? I can speak for the Kansas City area. We've got 4 major health systems. In my view, it's all about market share and higher price and cost. It's not about quality and cost efficiency. I don't know where you folks are in that equation. I've already talked about the place of training and cost. We need to pay attention to the ethics of consolidation. Part of it's market share. How about referrals? What about the employed situation where the system or whoever the employer is incentivizing physicians of all specialties to keep stuff within the system when you know you can refer the patient elsewhere for the same test or quality at lower cost? We have a diagnostic imaging center group in Kansas City that doesn't charge, well, that charges much less than the university and the academic health centers. But there are family physicians and others in those systems that are incentivized to keep patients in the system when they know it's not better quality and it's certainly much higher cost. That's an ethical dilemma that family medicine needs to shout about, talk about, and work on. How about site-neutral payment? From a patient perspective, I find it unconscionable that we are charging facility fees and patients have to pay higher out-of-pocket costs simply because a hospital has bought a practice or things of that nature. We ought to be shouting out about that. If there are reasons that hospitals need certain financial support for burn centers and things like that, let's have that conversation. But don't put it on the backs of patients through higher copays and deductibles because of site differences in site payment. Makes no sense whatsoever. And family medicine should be talking about this. Going back to equity in a different way, how about admissions to medical schools? The diversity of this nation is remarkable, but look at the diversity of those we admit to medical school, and it doesn't match the population at all. Shame on us. Shame on us for thinking about MedCat scores, MCAT scores as the ultimate decision of what makes the best and brightest. We need to be, the admissions process of medical schools writ large in this nation needs to be retooled, and it needs to be much more diverse in terms of the people that we admit, both in terms of gender, race, ethnicity, color of your skin, et cetera. We need to match the population of this country or we will not achieve health equity. Family medicine needs to call it out. How about gender pay gap? A great article in Health Affairs just last month or 6 weeks ago that showed that At the time of residency graduation, the gender disparity in payment between men and women in medicine begins day one with the first job after graduation from residency in any specialty. How is that fair? We need to call it out. Family medicine and departments can do that. How about patient-centeredness? We've been talking now for about 14 years about patient-centered medical home, more patient-centered care. That's great. One of my good friends is CEO of the National, Deborah Ness is head of the National Partnership of Women and Families. Deborah has this great emotional phrase of, if you invite me at the beginning, think consumer, I will be with you to the end. Are we inviting patients to be part of our discussions? Need to think about it. And finally, how about re-embracing being present with our patients? Gail Stevens described that way back when. When and where they need us, we need to be present with our patients. And our good friend Bill Phillips from the University of Washington said it this way: you can pretend to know, you can pretend to care, but you can't pretend to be there. You have to be there. So, we celebrate "50 years of great leadership of this department. Primary care is number one. UNC's number one in primary care. Top 5 consistently in family medicine. Congratulations. Great leaders. Thank you, Christy and Margaret and others and all the faculty. And I use the word great intentionally, because going forward, as Rosalind Carter said, there's a difference between being a good leader and a great leader. A good leader takes people where they want to go. A great leader takes people where they ought to be. We need to take family medicine where it ought to be. So, happy anniversary. Thank you for having me. Look forward to your questions. We have time and all for questions?
Well, you did more than inform, you inspired. And I honestly can say that's one of the most inspirational talks about family medicine that I've ever heard.
Thank you.
So we are so grateful for your leadership and inspiring us today to go out the door and lay the groundwork for the next 50 years. And you gave us a roadmap and a great set of ideas on what we need to do. I'm sure there's lots of questions and thoughts. Is there any pressing issue or question that somebody would like to ask?
Brooks has a question. Brooks Wilkins, stand up. Yeah.
Yet we don't have the proper metrics to identify, are we doing what we need to be doing to provide this quality? If someone comes back to see us in the office, we think we're practicing good medicine because they keep coming back. But is that the case?
Yeah.
You know, and if they live and don't die, does that mean we have practicing good quality? How do we show we're practicing good quality so we can pass that information to other specialties and to the insurance companies to let them know that we're at the top of the game?
Right. Thank you, Brooks. So because we're recording, I'm going to repeat the question very quickly. Brooks Wilkins from Raleigh, one of my residency buddies 2 years ahead of me here at Chapel Hill, asked the question about how do we determine and define quality. I think it gets back to my earlier comments, Brooks, is that the train has gone down the wrong track for the last 15 years, and we've created this quality measurement enterprise that's based on these process measures that are disease specific. Now, that may work okay for our subspecialty colleagues. It doesn't work for primary care. We need to be judged, I think, as I said earlier, on comprehensiveness, continuity, first contact, being accessible, pick up the phone after hours, etc. That's what primary care needs to be judged on. And when judged on that, it shows, in fact, that health care and health improves at the population level. There are, through the National Quality Forum process, there are now measures that are being tested for comprehensiveness and continuity, and hopefully we can redirect at least the quality train for primary care back to the 4 C's. And I think that's where we in primary care can demonstrate quality. That, however, I think needs to diverge from subspecialty care and how they will be judged.
Artie.
Artie, good to see you. Yes, sir. You learn from the master, Artie.
Cyber communicating with them every day. It's not even face-to-face anymore.
Right.
And also for the leadership of the specialty and primary care in general, how do you see that pushing and pulling? Because that's where some of the education needs to occur, really.
Good question. I don't have all the answers, but I can tell you that in conversations that we have at the Academy with our subspecialty colleagues, when you begin to talk about alternative payment models, they all of a sudden discover the value of primary care, because they know that their referrals will depend on us. That is not true generally with fee-for-service. But when you're talking about global capitation within, for example, accountable care organizations and so forth, they begin to pay attention. They understand that evolving quality and cost data will be available for primary care, so they're being judged compared to their colleagues, cardiology, whatever the case may be. And they begin to have interesting conversations about more population-based care and the need for referrals and the less need of certain services. You know, we all know this, one of the greatest values of primary care is its parsimony. Sometimes less is more. And our subspecialty colleagues have not been trained that way, but they're discovering a bit of parsimony because they know that the payment model is going to change. So I think we just need to continue those conversations and be bold and challenge them.
Okay, it's 1 o'clock, so we'll stop. Thank you again, Doug, for your inspirational leadership and your fantastic Huntley Lecture.
Thank you.
I have just a couple comments. First, I'd like to thank the Planning Committee for this year's Huntley Lecture, and I just have to call out Adam Goldstein, Brad Wilson, Reed Johnson, and Dion Apple, who did a marvelous job planning this. And also a shout out to Katie Coles, who's taking our picture right now, who helped create the beautiful posters that are along the wall there that depict the history of our department. I'd also like to ask you to complete the evaluation forms that are in your brochure and to either leave it on the table or on the table when you exit the room. And lastly, if you're interested in learning more about the history of the UNC Department of Family Medicine, we have the just released book on the history of the department available in the lobby for anyone who makes a gift of $100 or more. And Jim Lee is sitting here. I have to give a shout out to Jim, who worked for 7 years on this book and through multiple revisions, and we are so grateful for you for documenting the history of the department to date. With that, thank you so much for attending this year's Huntley Lecture, and have a safe trip back to work. Thank you.